So thank you for taking time out and being here today. My name is Inga Damanti. I'm from the Center for Patient Safety Research, and also I'm the academic from the Public Health Faculty, Universitas Airlangga. So I will be the moderator for today's lecture. So today's lecture is a collaboration between Center for Patient Safety Research and the Department of Health Policy and Administration from the Faculty of Public Health, Universitas Airlangga, with John Hopkins University School of Public Health. So we will have a presentation about the science of patient safety that will be delivered by Professor Cyrus, engineer. But before we start, in this very special event, we have the Faculty of Public Health Vice Dean Vice Dean for Research, Innovation, and Community Services, Bapak Trias Mahmudiono, MPH, PhD, who will deliver an opening remark. Pak Trias, the screen is yours.
Okay, thank you very much, Bu Inga. Assalamualaikum warahmatullahi wabarakatuh. Yang kami hormati all the seniors, professors in Universitas Airlangga, not only Faculty of Public Health, but also our colleague from other faculty like the nursing faculty and others. Also our honorable speakers, Prof. Cyrus, engineer from John Hopkins University. Thank you for your time, Prof. I know in the US right now is still counting the ballots in Nevada and some other state, right, Prof?
That's right. That's right. We are keeping our fingers biting, you know.
Yes, yes,
right.
Yes.
Right,
and thank you for Dr. Inge and the team from the Center for Patient Safety Research of Universitas Airlangga, who's initiating this collaborative event and a guest lecture from expert through the Fulbright specialist scheme, if I'm not mistaken. Prof. Cyrus, myself, I was graduate from Kansas State University through Fulbright scholarship. So we have something in common related to Fulbright. Once again, thank you for sharing your knowledge and time with us. As Vice Dean for Research, Community Development and Collaboration, I would like to extend the opportunity this time, not only related to guest lecture. We hope that this will also open up the opportunity for other activity later on, Prof. We have the Center for Patient Safety with Bu Inge. We will provide some internal funding for Airlangga for next year related to research grant that has to be related with or collaborated with other expert overseas. So this is going to be a good start up, maybe for the Center for Patient Safety Research to go beyond the what we call guest lecture, but it's a good start, Prof. And thank you very much. We have more than almost 400 students and colleagues joining this event. Thank you very much once again. And unfortunately, our dean has another meeting today with the Center for Public Health Association in Indonesia. So on her behalf, I send the regards and thank you and the gratitude for Prof. Cyrus. And in Indonesia, actually, Prof, patient safety research is not what do you call? It's not that really a mainstream yet. So we have a big opportunity to spread to the world what have been happening in Indonesia related to patient safety. And we believe that Dr. Inge and colleague will be the leading spears to Indonesia patient safety concern later on. I think any form of collaboration, even is research or maybe action research or community services, and also perhaps next year if we still have the program, I would be happy to invite you to Indonesia if the COVID condition is being solved. We have some programs such as a young professorship that you might be interested for the next year. And also please extend our gratitude to the Faculty of Public Health at Johns Hopkins University. In Erlangga, we also have 7 departments, not only health administration and policy. With ini ada Bu Tini and Pak Hakso, maybe the department head. We also have health promotion, and then environmental health, occupational safety, nutrition, epidemiology, and biostatistics. So this also open for collaboration and any type of engagement with academic or for community services, Prof. Also, if maybe some of your students want to have what do you call, like fieldwork experience in Indonesia or research, we will be more than welcome to open up with hosting them as well as other lecturer. And we hope that this is a good start for Erlangga and Johns Hopkins Bloomberg School of Public Health to strengthen what have been a good relationship we have, but we might be able to scale up later on. Thank you very much, Prof, once again, and Bu Inga and colleague, please don't forget to take the opportunity and learn a lot related to what Prof Cyrus is going to share with us. Thank you very much, everybody. Happy learning and sharing. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you.
Okay, thank you so much, Patrias, for the opening remark and also the support. So, okay, so I would like to introduce you to today's presenter, Professor Cyrus Engineer. So I will read his short biography, or maybe I just do the share screen. Okay. Okay. Yeah. So Professor Cyrus Engineer is an expert, a management expert with over 25-year expertise in building capacity for quality, patient safety, and performance management in diverse international settings. So he is an associate faculty at the Armstrong Institute for Quality and Patient Safety at Johns Hopkins. So he has an experience leading so many patient safety projects. I think it's around the world, in India, in Qatar, also in Afghanistan. He also led the global campaign for WHO related with the hand hygiene. Professor Cyrus is also a trained quality assessor for the Baldrige Excellence Award. And also he has provided leadership to educational program in the US and also in other countries. So yes, he has been an assessor and reviewer for accreditation program and has developed and taught courses in management, leadership, quality and patient safety and high performing organizations. So this is a very wide opportunity for us to collaborate and also for making connection. So we are very grateful that we can learn from you today. So you can start the presentation, and for the audience, enjoy the presentation. Thank you so much. I'm sorry, just small housekeeping before I forget that. For the audience, if you have a question, you can just write or type your question in the chat box, or maybe you can raise your hand using the button, and then you can ask directly to Professor Cyrus. And also we have here Dr. Muhammad Ardian, maybe to help me if I have problem with the connection. Okay, thank you so much. Okay, Prof. Cyrus, you can start. Thanks.
Thank you so much, Inge and Professor Mohammad and the Dean. It's a pleasure and an honor to be here speaking to all of you. I hope you can hear me. Can you all hear me? Yeah, just
Yes, good, Prof.
Yes.
okay, good, good. I hope we don't have any technical issues. I always worry about technical. I'm not the most competent, but my hope is that we will sail through. These are interesting times in the United States, as you might know. COVID and the elections, both sort of keeping us busy. And this is a good opportunity for me. Your kind words, Professor Trias. Clearly, we are not. This is not a one-off session. My hope is that we take this further along, invest in a relationship that can be built further, and I'm happy to share. My goals are to build capacity, and that's what I have. I'm originally from India and actually had a bad experience when I was a kid with a doctor where I was not, there was a misdiagnosis, and that led to me missing a school year, and lots of tests and a false negative test that came out. And since then, my focus has been to address quality and patient safety, starting with my own experience. So my hope is that today I'm able to sensitize the groups about the importance, the relevance, some concepts, and then next session the hope is to sort of focus on the how. Yeah, I have worked in. I've worked in. Okay, I think there's a mic that may need to be muted. If that's okay, I would appreciate that. I've worked in India. I've led a hospitals in India. Been a CEO of a hospital also, and I always see, sometimes when things happen, cases that are supposed to be routine, something as simple as a routine appendectomy, where you expect everything to come out okay and the patient to go home. You sometimes find some complications, and before you know it, the patient is in the ICU, the intensive care unit, and then you just are in shock and disbelief. The patient's families, etc., don't really understand, and we all believe that this is God's doing. This is something that was meant to happen, but not all the time it is what fate has to achieve. There's a lot of human error. So what I want to do is, if it's okay, I want to first thank and acknowledge the work of my colleagues. This is not all my work. I want to make sure that this is the work of teams and people who are eminent leaders. I'm one of them in this whole group. I've worked with WHO in patient safety, which is the World Health Organization, spent some time in Geneva. And then I've also been at Johns Hopkins, where I work with quality and patient safety efforts. So I'm going to use both Johns Hopkins and WHO. I have the pleasure to acknowledge both teams in both these environments. And my hope is, what I tried to do was, it was hard. Should I speak about work out of Hopkins, or should I speak work out of WHO? But I thought it might be a good idea to combine both of this. So what is this presentation scheme is WHO, but it includes a lot of work from Johns Hopkins. Okay, all right. I have a question. Is my audio, tone, pace, speed of speaking okay?
Okay, Prof.
Yes, it's
Okay.
okay,
Are you
Prof.
following? All right. If you can't, so what I'm going to do is start with a small clip, and I hope technology cooperates. We tried this, but so let's see if this works. Okay. So let's see. Are you able to see the screen? Are you able to see the screen?
Yes, cool. Yes, Prof.
Yes, Prof.
Okay, now I'm going to see if you can.
We had a very real expectation of being treated compassionately, of understanding, of certainly being told the truth.
Sir, question is,
And we found that these people weren't engaging with us at all. They were looking after themselves, and they were looking after their system
Prof.
and their
Cyrus,
organization.
Yes.
And
we did not see the
we
video,
don't,
we see the
we don't,
folder.
the
Yeah,
hospital.
perhaps you should like stop screen and then share the video one.
Sorry? Sorry?
I think you should share stop screen and then share the video again.
Okay, let me
Yeah.
try doing that. So stop. How do I, it's not allowing me to stop sharing screen. Okay, share, stop. It's not allowing me to stop sharing the screen, but okay. Okay, can you see? I'm going to stop share now, okay? And I'm going to share screen now, going to the other one. Hopefully. Can you see this now? Can you see the video?
Not yet.
Yeah, but
You
so
the folder, Prof. I think you should open the video first and then pause it and then you click the share on the video.
Okay, I'll do
Not
that.
the folder, yes.
Okay. Are you able to see it now?
Yes.
yes, sir.
yes.
Yeah.
Yes.
I'm so sorry. Okay, let's hope it works now.
We had a very real expectation of being treated compassionately, of understanding, of certainly being told the truth. And we found that these people weren't engaging with us at all. They were looking after themselves, and they were looking after their system and their organisation. And we just didn't seem to come into the equation at all.
I rang the hospital very quickly afterwards and nobody bothered to return my call. And I think that this was really the first taste of the cruel way that I feel that I've been treated by that hospital ever since.
Bit by bit, as the pieces came together once we acquired the records, it was shock, panic, terrible, terrible sense of violation, because we realized that our daughter had suffered unnecessarily. Information had been withheld from us, misinformation had been provided to us, and so it was on top of our daughter's unnecessary suffering and possibly avoidable death. The sense of violation of our trust was very, very hurtful.
I tried to ask for help from the hospital, but they said no. I managed to live 16 years fighting no justice, but still keeping on fighting. The more I fight, the more I lost, till I went bankrupt, and also lost on the way down to human dignity.
We kept taking Cal back to our local doctors, saying what's wrong with our baby, and they would say nothing. So when Cal was a year, I set up an appointment outside of our state at a university, at one of the top universities in the United States. and they had requested all of his documents from his birth, which I had never seen. And so when I took Cal to this team, the team said within the first half an hour, they met Cal and me, and they said, showed me a document. They said, Mrs. Sheridan, haven't you ever seen this document? And I said, I don't know what that is. And they showed me the results of Cal's MRI. It clearly stated he was
I do think everybody wants the truth, however uncomfortable it may be for either or both parties. All anybody wants is simple human honesty and communication.
I have no doubt that we all want the same outcome, the best outcome, but when the best outcome doesn't happen, people run for cover, and it's indefensible. It really is indefensible. And as well, medical people don't realise that when they don't treat us properly, they're actually creating other patients. We go away sick at heart and sick in body.
Not acknowledging your wrongdoing, you're telling me that my blessed child counted for nothing. And that's what's caused me so much grief, because whereas I can accept her death, I can't accept that I wouldn't get some form of accountability.
Trust is the essence, I think, of good healthcare. We have to build a system that allows for patients to trust their physicians in every way. Not only that the physicians are doing their best and learning from errors, but also ethically that they're always acting honorably.
Any patient who has an injury needs to be told, or even the family, if the patient is too sick, that there is a problem. Even if it's bad news or good news or whatever it is, we really need to know.
Que es importante que los médicos estén conscientes de que pueden cometer errores. Y todos nosotros sí estamos conscientes, son seres humanos al final de la película. Pero lo que es importante es, si ya cometiste un error, ya no lo vas a poder reparar, pero no le digas no le ocultes la verdad a la familia, no le ocultes la verdad a los padres, porque les estás haciendo todavía más daño.
The system seems to say, thou shalt never apologize. And I want that changed, big time.
How would you have liked to have been treated then, or how would you hope that families in the future will be communicated with after a fatal mistake?
In a word, with humanity, because it isn't a humane system at the moment. And people don't recover. People aren't allowed to recover. You see, if it were done properly and if it were done openly in a fair way, I would have gone away and I would have grieved over my dead boy. But I would not have been blaming anybody. And the people who were involved in his care, in his unsuccessful care, would have learned lessons that would have maybe allowed them to recover and then work more effectively in the future. And that's what we're being robbed of. The system has actually been deprived of that opportunity to learn from tragedy.
We all make mistakes and errors, even if we're good, careful, conscientious people. And so we have to recognize that to reduce the harm to patients, we can't simply just urge people to be more and more careful. We want them to be conscientious, but we will reduce error, but particularly reduce its impact by strengthening the systems and processes and environments in which our doctors and nurses work. If we run cultures in our hospital which major on blame and retribution, then our staff will be afraid to admit their mistakes, or they'll even cover them up for fear of being disciplined. And if we don't know about the things that go wrong, no learning can take place, and perhaps the tragic experience of one patient won't help or benefit anybody else.
Que son seres humanos, que no son objetos, de cual nos puedan decir, es un accidente, perdón, lo sentimos. No estamos hablando de un objeto material, cual se pueda sustituir como un auto, una casa, si no estamos hablando de personas. Personas que tenían ilusiones, que tenían sueños. Y yo creo que lo más importante para los médicos es eso, estar conscientes de que son seres humanos. Confía en ellos como profesionales en su campo.
It is so hard to articulate the profound sense of betrayal and abandonment that my family felt. I can only describe it as a hit and run in medicine. My family was abandoned on the side of the road, injured and traumatized by a well-meaning motorist who fled because of legal and personal fears. We were left to seek out help on our own with our own resources. No one looked back. It was pretended as if nothing had happened, including those eyewitnesses on the side of the road. A hit and run in our world is considered criminal. Why is it okay in medicine? The non-disclosure of medical error is the most destructive phenomena in healthcare. Trust and confidence disappears in a heartbeat. You know, disclosure and transparency is simply a new kind of glitzy way to say the word honesty. And I know of no other industry where honesty is optional.
So I'm going to, this was a video about experiences of patients who had harm to their family members. And they came to find out the hard way, not the way they should have found out. They came to find out, you know, later on, or you know, in ways that you don't usually expect. They expected that if there's a mistake that's made in the care process, somebody would tell them, honestly, we made a mistake. So when I'm doing this session face-to-face via Zooming, I ask each one of you, and you are over nearly 500 people, do you ever feel that somebody that you love or has been part of has faced this situation where they've been harmed? Yes or no?
Yes,
a family, a friend.
Yes. Yes, sir.
Okay. So how many times has somebody come up to you, a healthcare professional, and said, listen, my friend, we messed up. We made a mistake, and I'm going to do everything possible to fix this. Disclosure of medical errors. There's non-disclosure of medical errors. And what Sir Liam Donaldson said, if you don't talk about it, if you hide it, it causes mistrust. It causes lack of learning, because think about what happened when, you know, the 737 Max, you know, these planes that Boeing manufactured, they crashed. 3 planes crashed or 4 planes crashed, right? They're learning. They acknowledge the mistakes. They're trying to fix that. And they talk about it and they say we made a mistake. Yeah. And so that's what we need to do in healthcare. If we have to have a system that's learning can only occur if we acknowledge. So if I ask people, when was the last time a doctor or nurse said, I made a mistake, I'm sorry. I gave you the wrong medication. I gave you the wrong drug. I did the wrong procedure. I discharged you early. Has that happened? Oh, by the way, I gave you the wrong medications. Can you come back to the hospital? Oh, that was somebody else's blood report. This happens, but in healthcare, we sort of, as professionals, aren't nearly quite there compared to many other industries. So with that, I just wanted to start off with the lecture on patient safety, on what we call the science of safety and what we all need to do to make it better. Can you see my slides again?
Yes.
Okay.
Yes, Professor.
Okay, so I'm not going to be able to see the chat, so please jump in and unmute yourself and talk to me, okay? If you have a question, please pause. Please pause. So what I'm trying to do today is to talk about the global magnitude of harm in healthcare. how much unsafe care is there globally. Share some concepts on patient safety, try to discuss some definitions and types of harm that occur in hospitals and healthcare institutions. I'll try to tell you a story, and then we'll spend some time on the science of safety. What is that all about? And then if we have some time, I'll tell you about some of the examples that WHO and at Johns Hopkins. Sound like a plan? Yep. Okay.
Yes.
So there were two reports that actually were published very close to each other. One report was published in the United Kingdom, which is called An Organization with a Memory, on your left. And the other report was published in the United States in 1999, which was called To Err is Human. The title To Err is Human is like, we are all humans, and to make a mistake is human. As humans, we make mistakes. We are not machines. We are not computers. So that was the title of this book. And it almost highlighted the big problem of unsafe care in the United States and in the United Kingdom, and how many people were dying of medical errors. Okay. So what do you think? Is this a big problem? Do you think this is a big problem? Yes or no? Do you think we harm patients?
Sure. Yeah.
Okay. So yes, you're right. About 10% of hospitals, 1 in 10, suffer an adverse event each year, according to that report. 1 in 10, which is 10%. The IOM report, To Err is Human, said in the United States alone, we have about 44 to 98,000 people dying of medical errors each year. Each year, we have about 44 to 98,000 people dying of medical errors in the United States each year. Now, as a country, do you know how much we spend on healthcare? We spend $3 trillion, or roughly 19% of the GDP. $3 trillion. We are the country that spends the most on healthcare anywhere on this planet. Anywhere. The United States spends $3 trillion, or 19% of the GDP, and still we have quality where we have about 100,000 people dying of medical errors each year. COVID is important, and in COVID, we have about 230,000 deaths, and everybody looks at it and it's an important number. But what if I told you about anywhere between 50 to 100,000 people have been dying since that publication of that report in 1999, but nobody talks about it, right? We don't talk about it as much. Why? Because it's a silent epidemic. It's a silent epidemic. So there's a lot of data here, and I won't talk about it, but infections, 1.4 million people are affected by infections. You go to a hospital and you want to step into a hospital believing it's clean, it's a nice environment. You go for a procedure, you go stay for a couple of days, and then you come out with an infection. And this is all in the developed country context, that what you're seeing. The situation in developing and transitional countries is even more grave. So this is what you call the magnitude or the burden of unsafe care. You heard that video, you saw that video right now? These are actual faces behind those numbers. And this is not just in one country. And this is not in low and middle income countries. This is happening here in the United States, in the United Kingdom, in Mexico, and in Indonesia. Yeah. All right. So what you see is this gentleman, Ian Kelly. He was 41 years old. He had MRSA, an infection, after he had surgery on his leg. He was ill for many years. It's an infection, that is hard to fight with antibiotics. There's resistance. And so eventually he agreed that his leg needed to be amputated. Yeah. And so he lost his leg to an infection, to a medical error. How did that infection occur? We don't know, but clearly something happened and he got that infection. Wayne Jowett down there is what you call an 18-year-old in the United Kingdom. Yeah, a chemotherapy drug was injected in his spine instead of a vein. So it was a mistake, an honest mistake, where instead of the drug being given in the vein was administered in the spine. Yeah, Josie King, I'm going to talk about her if we have some time. An 18-month-old child died at Johns Hopkins, at my institution, Johns Hopkins Hospital, many years ago, about 2 decades ago. Of what? Dehydration and misuse narcotics. Dehydration at what is considered as one of the world's best hospitals. Yeah, you can look at US News and World Report and type in Johns Hopkins and you'll see that it comes on top in terms of a medical institution. But this baby died of dehydration and misuse narcotics. And there are many more faces right here. So those numbers are there, but there is a face associated behind that number. So there are people and there are lives. How are we doing in healthcare? As an industry, how is healthcare performing compared to many other industries when we compare other industries? So what you see here is a chart that compares the size of the industry, the size of the bubble is the size of the industry. And then on two axes, one is productivity, which is the x-axis, and then quality, which is the y-axis. Lower, and you have a high error rate for quality, which is bad, and low error rate for quality, which is good. So you really want quality on the y-axis to be top right there. And on the x-axis, you have productivity. You want to see more patients. You want to see more people. You want to treat more patients because there's never enough healthcare. And so the x-axis is all about productivity. So where do you think healthcare is compared to other industries? Try to read that graph and tell me, where do you think healthcare is? Where would you like healthcare to be and where is healthcare right now? Yes.
In high error rate, but in low productivity.
Correct. And where do you want healthcare to be?
Low error rate.
High productivity.
High productivity.
Yeah. A low error rate and high productivity. That's the quadrant to the top right, right? That's where telecommunications is. That's where banking is. That's where airlines is. Do you ever think twice before stepping onto a plane that you are not going to reach your destination? Do you worry that you're not going to, when you fly, do you worry that you will crash?
No.
Sometimes. Why not?
Sometimes.
Okay. Do you worry that when you dial a phone number, it's going to reach somebody else?
No.
Yeah, sometimes.
No.
Sometimes it happens, but very rarely, right?
Yes.
Don't you ever wish that when your company, when your employer transfers your pay every month, do you get paid every month or do you get paid bi-weekly in Indonesia?
Every month.
Every month.
Okay, so don't you ever wish that there is a mistake by the bank where the decimal point is put two places to the right instead of, maybe 2 or 3 places to the right? Don't you ever wish that?
Rarely.
Yeah, I wish that all the time. Why can't they move those 2 decimal points? Even though I'm a professor, why don't they ever make a mistake? And why don't they round up? If they don't move the decimal point, if it's 49 cents, why can't they round it up to 50 cents? I even have that problem, but it never happens, right?
Yes.
You do e-banking, you transfer money, it is transferred. You don't have to check it again. But in healthcare, if I want to find out if my patient is discharged, I have to make 4 calls. Sometimes the patient is discharged. Sometimes the patient is somewhere else. I really don't know what's going on. Yeah. So I think we have a long ways to go. That is what we have in healthcare. Healthcare is lagging behind many other industries in safer care. So I just told you a while ago that, you know, we kill about 98,000 people each year of medical errors, right? That was the report I just showed you. So medical errors is that big bar. Each year, how many people die in the United States from motor vehicle accidents? About 43,000. From breast cancer, about 42,000. From HIV, about 16,000. From drowning in water, it's about 4,000. Where do you see medical errors?
89.
Yeah, it's sort of high, right? So what I did was I said, okay, let me try to understand how many planes full of passengers would crash each year if I put those 98,000 people into the planes. You know, a jumbo jet is out of commission now. It's just called a 747. It carries about 300 to 400 passengers. So if I had to put those 98,000 people into planes, it would be about 240 planes crashing each year in the United States. 240 planes, not one, not two, not one 737 Max. So now my question to you is, if you knew that airlines was not as safe as had that history or that track record, would you step onto a plane?
No.
No, Prof.
Oh,
I will choose another.
You would not step onto a plane, right? I would drive, I would walk, I would bike, but I would not get onto a plane. That is the issue in healthcare. This is just another way of showing you, okay? Yeah, somebody just raised a hand and please speak up. I'm not able to see the chat, so it might be good to speak up. Or somebody can read the question for me, that would be terrific. Okay. All right, I'm not sure. Should I move on?
Yeah, I think we take the question maybe after the presentation. That's better, Prof. Thanks.
Okay, and there's a lot of content that I have to cover. So if you can bear, that'll be great. But if you have a burning question, please jump in. So there's a growing burden of unsafe patient care globally. There are adverse drug events because wrong medications are given, which we don't track. There are improper blood transfusions, transfusions, blood groups. There are surgical injuries when surgeries are performed, perforations and other things that we don't typically capture. There's wrong side surgery, you say right hand, but sometimes it's the left hand. If you say the right leg, sometimes it's the left eye or the right eye. So there are wrong side surgeries, or there are sites that are not appropriate. There are restraint-related injuries, when patients are not cooperative, you sort of put restraints on them on the bed. There are patient falls. How many of you know about patient falls that occur in the hospital? A lot of patient falls occur because, they want to go to the toilet, or they want to just move out from the bed, and they press the call bell, and then we are too busy, and so they decide to sort of go walk themselves, except they have a spell of dizziness and they fall down. Then there are pressure ulcers or bed sores. If patients are lying without their backs, on their backs for a long time, they get bed sores that become septic. The same patient with the same name, sometimes they get the wrong treatment. There's mistaken patient identities. And then the big elephant in the room is infections, which we'll talk about in a bit, okay? So there's a huge problem of unsafe care. So let's think about patient safety as a definition. What is patient safety? This is there are two definitions. One's the more complicated definition, the longer definition that you see at the top, and the other one is the simpler definition. So you can read this, but it's basically avoiding accidental injury. Yeah, so that's broadly the definition. You avoid, prevent, and stop adverse outcomes or injuries from the processes of healthcare. So that's the broader definition. So medical errors, what are medical errors? They can be defined as the failure of a planned action to be completed as intended. You had planned something to do and you did not do that, or use a wrong plan to achieve an aim. So you get a medical error. So that is the definition per IOM, the Institute of Medicine, which published that report, which is a think tank in the United States. What are the different types of errors? You have different types of errors, right? You have diagnostic errors, you have treatment errors, you have preventive errors, and you have other errors. So diagnostic errors are errors which is because of error because you did not diagnose the thing properly, because you did not take proper history, or the lab tests were not reported accuracy, the accuracy or the reliability of the lab testing or the radiology, or just it was a delay in diagnosis. That's also, if you delay a cancer diagnosis, that's also what you call you miss a cancer. So that's also a diagnostic error. Then you have treatment errors. Errors because you do something like an operation, like a surgery. So that is a second classification of error. The third is preventive, which is you should have done something like diabetes screening, HbA1c, or something that should have been done, and you did not do that. That caused something serious later. That should have been done. So that's a preventive failure. And then there are other types of failure which are more common, which is communication, and we'll talk a bit about that, or equipment failing or things like that. So these are the different types of failures that we have in healthcare. Okay, are we good? Are we good so far?
Yes, Prof.
Good, sir.
Okay.
Yes, well.
Okay, so what are the implications of these unsafe care? You know, when we have unsafe care, you know, there's injury, there's disability, there's death, and that's personal loss. It's not just personal loss, it's societal loss, lost incomes. People spend money to pay their hospital for hospitalization. They get an infection, they stay for 23 days instead of 8 days or something, and they become bankrupt. So they lose their jobs, they lose their incomes, and it also affects household productivity. More important, there's loss of trust in the healthcare systems. People lose trust, you know, and faith, like you saw from that video before. And then you have rework and unnecessary waste, okay? It's what IOM defines overuse, misuse, or abuse of healthcare services. So that happens, overuse of healthcare services, when sometimes you have to do the test again because the medical records are lost or they're not correct. So my question is, can all medical errors be avoided? Do you think all of these can be avoided? All medical errors can be avoided?
Not all, maybe.
Not all, maybe.
All, maybe.
Yes.
Not all, but most can be avoided, and most are preventable, right?
Yes.
That's what it is, okay? So why do these occur in the first place? Why do medical errors occur? What do you think? They are preventable. Some of them, you know, they are preventable. They're not like cancer. We know where we don't have a cure, right? These are preventable. So why do these occur in the first place? Inge, you're not allowed to speak.
I'm just opening my microphone. Okay, then I'm gonna.
Okay, no worries. We'll find out in a bit. But the problem is that healthcare is a decade or so behind many other high-risk industries in its attention, okay? So unlike nuclear industry, you know, or many other industries in healthcare, we, as you saw from the chart, you know, we are behind. We have a lot of learning, and this is the example. So what you're seeing here is a chart of simulated data, a data that is simulated in a publication that shows if in an average hospital that has about 350 beds, on average in a year has about 14,000 admissions and conducts about 5,500 surgeries, what is going to be the distribution of medical errors or adverse events? What is going to be the distribution? Based on historical data, based on trend, what are the most common, the top 3 most common errors that are going to occur if you were to go to a hospital? And the first one is decubitus ulcers or bed sores. The second big one, which we'll talk about, is nosocomial infections. Yeah, yes. I'm assuming you all have a good sense of what infections are, how they are caused. If not, we can discuss that later. And the third one is adverse drug events. Yeah, so the top 3 are ulcers, infections, and adverse drug events. So this is in an average hospital, which is a community hospital, not an academic medical center that's not doing high profile cardiac surgeries, neurosurgeries, etc. This is what you're likely to see. Okay, that's sort of telling. 952 cases of ulcers or 770 cases. So this is data from the United States. This is data from the United States. In the United States, we have 1.7 million infections, or an infection rate of 4.5% each year. So, and about 100,000 people die of infections each year in the United States. These infections are again further classified into infections due to pneumonia because they are associated with ventilators. BSI is bloodstream infections, when you have a central line that is put inside and it's not carefully regulated, you get a bloodstream infection. So about 30,000 deaths, 30,500 deaths due to bloodstream infection. Then you have UTI, urinary tract infections. So when you have a catheter that is placed in indwelling catheter, more than what it needs to be there because of convenience, sometimes because of patient preference, you have the catheter. And so that causes about 13,000 UTIs. And SSIs are surgical site infections. So there are about 8,200 surgical site infections. So clearly this is an epidemic. Clearly this is a silent epidemic. Clearly this is not something that's reported. And it's actually bigger than many other known reported diseases. So patient safety is a big problem in the United States as well. Now, this is an important schematic. What you see, those numbers are the numbers that we know because they were reported, right? Because there was somebody who was honest, somebody said, let's report these numbers because there was an infection and we can report this. But there are times when, many times when you don't report these infections and they are unreported. So this is what we call the tip of the iceberg. There may be a bigger problem, a larger problem that is beneath the water that we have not even seen as yet. Okay, and so with that, I'll sort of, I can bring you to another video about this child who died at Johns Hopkins Hospital. Would you like to see that?
We still have 3 minutes left, Prof. Cyrus, so I think, yeah, we are fine.
Yeah, okay. I just want to make sure that technology cooperates, and I might need your help again if I am stuck here. Okay, so just hold on. Thank you.
The following video is from a presentation that Sorrel King and I gave. Sorrel is really a hero of mine.
Okay, now I'll do what I was told. I hopefully should be able to. Okay, can you see this?
Her 18-month-old Josie died at my improvement for healthcare. The following video is from a presentation that Sorrel King and I gave to the Institute for Healthcare Improvement's Impact Network this fall. Sorrel is really a hero of mine. Her 18-month-old Josie died at my hospital as the result of medical mistakes. Sorrel and I are working together now, partnering to try to ensure that this doesn't happen again. She would like to share her story with you, and then we will discuss how we're partnering.
My daughter Josie died a year and a half ago at Johns Hopkins due to medical errors. Last week, I had the opportunity to speak at grand rounds to the doctors, nurses, and leadership of the hospital. I spoke about what happened to Josie and about the Josie King patient safety program that is being launched. Reliving our tragedy was a painful and difficult thing for me to do. When Peter asked me 2 days later if I would be interested in going to Boston to speak at this conference, I quite honestly was not sure I had the strength to do it again so soon. After thinking about it, I realized I had to be here. Not only do I represent Josie, but I also represent all of the other children, the mothers, the fathers, the sisters, the brothers, the 98,000 people who die every year in this country from medical errors. I'm here for them, for their families, and for any future potential victims. I would like to share my story with you. I do this with the hope that what I'm about to tell you will make a difference in how you care for your patients and how strongly committed you and your hospital are to patient safety. Josie was 18 months old. She had brown eyes and light brown hair. She loved to dance and had just learned to bounce on the trampoline with her older siblings, Jack, Relly, and Eva. She had just learned to say, "I love you." In January of 2001, Josie was admitted to Johns Hopkins after suffering first and second degree burns from climbing into a hot bath. She healed well and within weeks was scheduled for release. 2 days before she was to return home, she died of severe dehydration and misused narcotics. I would like to take you through the events that resulted in this needless tragedy. Josie spent 10 days in the PICU. I was by her side every day and night. I paid attention to every minute detail of the doctors' and nurses' care, and I was quick to ask questions. I bonded with them and was in constant awe of the medical attention she received. Every time Josie moved or fussed, someone would be quick to push her pain button. I tried rubbing her head and found that often this would settle her. Much to our relief, Josie was experiencing a quick recovery. Her burns were healing beautifully. She was sent down to the intermediate care floor with expectations of being sent home in a few days. Her 3 older siblings prepared for her welcome home celebration. We were told that no one had ever been sent back up to the PICU. The following week, her central line had been taken out. I began noticing that every time she saw a drink, she would scream for it, and I thought this was strange. I was told not to let her drink. While a nurse and I gave her a bath, she sucked furiously on a washcloth. As I put her to bed, I noticed that her eyes were rolling back in her head. Although I asked the nurse to call the doctor, she reassured me that oftentimes children did this and her vitals were fine. I told her Josie had never done this and perhaps another nurse could look at her. After yet another reassurance from another nurse that everything was fine, I was told that it was okay for me to sleep at home. I called to check in 2 times during the night and returned to the hospital at 5:30 in the morning. I took one look at Josie and demanded that a doctor come at once. She was not fine. Josie's medical team arrived and administered 2 shots of Narcan. I asked if she could have something to drink. The request was approved, and Josie gulped down nearly a liter of juice. Verbal orders were issued for there to be no narcotics given. As I sat with Josie, I noticed that the nurse on morning duty was acting very strangely. She seemed nervous, overly demonstrative, and in a hurry. Uneasy, I asked the other nurses about her, and they said she had been a nurse for a long time. Still worried, I expressed my concern to one of the doctors, and he agreed that she was acting a bit odd. Meanwhile, Josie started perking up. She was more alert and had kept all the liquids down. I was still scared and asked her doctors to please stay close by. At 1 o'clock, the nurse walked over with a syringe of methadone. Alarmed, I told her there had been an order for no narcotics. She said the orders had been changed and administered the drug. Josie's heart stopped as I was rubbing her feet. Her eyes were fixed and I screamed for help. I stood helpless as a crowd of doctors and nurses came running into her room. I was ushered into a small room with a chaplain. The next time I saw Josie, she had been moved back up to the PICU. Doctors and nurses were standing around her bed. No one seemed to want to look at me. She was hooked up to many machines and her leg was black and blue. I looked into their faces and said to them, "You did this to her, now you must fix her." I was told to pray. 2 days later, Jack, Relly, and Eva were brought to the hospital to kiss their beloved Josie goodbye. Josie was taken off of life support. She died in our arms on a snowy night in what's considered to be one of the best hospitals in the world. Our lives were shattered and changed forever. Josie died from severe dehydration and misused narcotics. Careless human errors. On top of our overwhelming sorrow and intense grief, we were consumed by anger. They say anger can do one of two things to you. It can cause you to rot away, or it can propel you forward. There were days when all I wanted was to destroy the hospital and then put an end to my own pain. My 3 remaining children were my only reason for getting out of bed and functioning. One day, I will tell them how they saved my life. Tony and I decided that we had to let the anger move us forward. We would do something good that would help prevent this from ever happening to a child again. It seemed the best place to start was with Johns Hopkins. Over the past year and a half, we have worked with the hospital to create the Josie King Patient Safety Program. Together, we launched the program last week. Josie's death was not the fault of one doctor or one nurse or one misplaced decimal point. It was the result of a total breakdown in the system. It was the result of a complete lack of communication between the different teams. It was the result of doctors and nurses not listening to a concerned parent. It was the result of a combination of many errors, all of which were avoidable. What if the nurse had called the doctor when Josie's eyes were rolling back in her head? What if she could have had a drink or had been hooked up to an IV? What if the residents had paid attention and seen that her weight had dropped over 15% in 24 hours? What if the nurse had not given her the methadone? What if someone had taken my concerns seriously? What if a patient safety program had been in place? I believe that if any one of these things had occurred, the outcome could have been different and Josie would be here today. 98,000 people die every year because of medical errors. Hospital errors are among the top 4 leading causes of death in the country. This problem is unlike cancer, AIDS, or other diseases where we must wait for a scientific breakthrough in order to save lives. Hospitals are a man-made epidemic. Nurses and doctors make mistakes and lives are being lost. These human errors need a human solution. You are the only ones that can solve this problem, not lawyers, not insurance companies, and not people like me. Much has to be done to accomplish this. We can start by first admitting to ourselves that we are fallible. The medical community must be open to the possibility that shortcomings do exist, and you must be prepared to make the necessary changes. Please take the time to listen to a parent when they are concerned. Please learn to trust a parent's instincts. Please communicate with each other, nurses to doctors, one team to another team. Please listen to the child. Is she crying because she's in pain, or is there some other reason? Please look at the child. Not all the answers are on your clipboards or computers. Thank you for listening to me today. For the past year and a half, I have known I would one day find the strength to share this story with those who can make a difference. My precious memories and everlasting love for Josie give me this strength, and I will not rest until we make something good come from her senseless death. I will not rest until hospitals become safer places. I am not asking for your pity. I'm asking for your help. I do not know the answers. I only know that there is a problem that must be solved. Some of the best and brightest doctors and nurses in the country are in this room, and I know that together, if we are all committed and work hard, we can control hospital errors and we can save the lives of other potential victims, other helpless children. Thank you.
Yes, there's silence, and I understand why. It's hard to fathom the loss of an 18-month-old, especially due to dehydration, yeah, at one of the best hospitals in the world. So anyways, so let's see if I can get back to. Can you see the slide again?
Yes, Professor.
Okay. It's a touching video, and it's occurred about 20 years ago. And since then, Hopkins, so just to tell you the rest of the story, what happened was that obviously there could have been a case, right? In the US, if somebody admits to a medical error, then usually you have a lawsuit worth millions of dollars. But instead, this was the time when Hopkins said, we made a mistake, and actually confessed to the mistake. And then, yes, there was a lawsuit, and yes, there was a settlement. But from the settlement, the mother said, you know, here's some money back, gave some money back to Hopkins and said, here's the money. I want you to use this money to have a patient safety program, and I'll come back in 5 years, and you need to demonstrate that your place is safer. And so that was the Josie King Patient Safety Program, which gave birth to CUSP, the Comprehensive Unit-Based Safety Program, that if we have an opportunity, I'm happy to discuss. This is changing the culture in the hospital, changing the culture where people are fine. Nobody is punished because they said they made a mistake, which enabled people to say they made a mistake. And not only just say that they made a mistake, but then try to address that mistake. And nobody's fired because of that. Nobody's let go. And not only that, you know, you ask people and people have started saying, how are we going to hurt the next patient who comes to our department? What can we do to fix it? So that's the CUSP program. That's Josie King. And since 20 years, this program has gone all over the world. It's in the United Kingdom, in Australia. It's been adopted in many places to improve the culture, because culture and clinical outcomes are closely linked. So it's about improving the culture. It's about being honest. It's about disclosure. It's about learning from mistakes. It's not about being afraid of mistakes. So that's the program at Johns Hopkins that was instituted about 20 years ago, and it's very successful. And it's been published about, I can share information about that. So my question is, how did we get here? How did we get here? All right, I guess. So, I mean, this was the book, this was the report that was published. What this said, that we killed so many people and we hurt so many people. It's not because of lack of knowledge. It's not because doctors and nurses don't work hard and they don't want the best care for their patient, but it's because of shortcomings in the way care is organized. It's, you know, we want teamwork, but we are not organized for teamwork. We train independently in different units, and then we come together, and there's lack of communication, there's lack of teamwork, and there are ways in which we do our work. This is a chart of workflow in a ward of a hospital. This is a chart of workflow in a unit in a hospital. The number of crisscross, the number of people coming in, going out, etc., actually tells you that, you know, there's not a streamlined workflow. There's lots of opportunities, lots of interactions, lots of touch points where mistakes could occur. And that requires extensive communication and a lot of teamwork. So this is just, the way we are organized. This is what the report said, that healthcare has safety and quality problems because it relies on old systems. Poor designs set the workforce to fail regardless of how hard they try. So it's not that if I try harder, I will succeed, but the system is set up in such a way that even if somebody tries really hard, there's a chance that you are likely to fail, okay? These are the reasons, and I won't go into each one of these, but these are the reasons, because healthcare, the doctor is supreme, and it's the doctor and all the decisions, and the doctor drives care and quality and is responsible. So the physician and the care team, so there's over dependence on the clinicians for care. People are trained in silos. There's increased complexity of care. Who owns the admissions, discharge, and transfer process? Sometimes there's so many people involved. There's so many handoffs that occur. You've got cost pressures. You want to treat people sooner, get them discharged from the ICU. And then unlike in finance, there's no vocabulary for patient safety. So that is another issue. So I'm going to give you some examples.
Prof.
Yes.
I'm sorry. You have 2 minutes left.
Okay. I'll go through it. Okay. Yeah, sure. Can I get 5 minutes? Is that okay?
Sure.
Okay. So what's wrong with this picture? I'm just going to go through this. There's something wrong, right?
Yes, sir.
Okay.
Yes.
What's wrong with this picture?
Unsafe condition.
Yes.
Somebody's trying to fix a light bulb electric wiring with a ladder which is in water, right? Something wrong there, right?
Yes.
Right.
What's wrong with this picture right there?
The letter is the structure of
That is superhero.
Okay, yeah, I want you to understand that these things happen. These are real pictures, by the way.
Yeah, it's wrong.
Yes, wrong.
Yeah, something wrong with that picture? Yes?
Yeah.
Yes.
Another forklift up.
Okay, now what's wrong with this picture?
It's size. The size.
Same color.
The design is
the sign.
Size is
the same color.
too risky.
Same design but different doses.
Right. There's a problem, right? Somebody wants to save money on labels, right?
Yeah.
But
Yes.
when you get used to a label and you think that's the medication, and then you can make a mistake, right?
Yes.
Yes, of course.
What about this?
The label.
Look alike.
Yeah.
Yeah, epinephrine and vitamin E, a vital drug there for saving lives. You could make a mistake. You could pick vitamin E because you see a label in a certain, you just remember that label and you pick that up and think that's epinephrine. Sometimes what happens if that label comes off? The label says it must be diluted, but sometimes the label can drop off. What happens?
It can be wrong use for
Correct?
Overdose.
You see here.
doctor
prescription.
Cannot read.
Yeah.
I cannot read.
I can't read it.
I cannot read.
certain
Sorry.
people can read this.
Yeah. It's not clearly.
This is the original on the right.
It's better.
Yeah, it's better, but
Yes, it's better.
Yeah.
when you put a carbon, you have a pharmacy carbon that goes to the pharmacy, yeah,
Yeah.
and they have to read because people keep scratching, there's scratches, etc. That's what happens on the carbon right there. So then they decided we need to print these and put carbons, yeah, print these. These are real from good old days, not now, but good old days. And so people can just fill and check the numbers here, so there can be no writing errors. Doctors' handwritings are particularly notorious because they think faster. My wife is a physician and she gives me a shopping list and I bring 2 things out of the 5 things and then she sends me back. I said, I didn't understand. So it happens all the time. So I'm like, I don't understand. The first 2 letters are nicely written. and then everything else is, so you have to guess, what medicine it is. So in this case, what happens is if the carbon moves, you may still have the same thing. You can still make a mistake. Does that make sense? You might mark somewhere else or put somewhere else, right? These are 4 catheters, which are, all there, and you can always make a mistake. If you are working for 12-hour shifts and you've had a bad day and you've had many patients, you can always make a mistake right there. And care is complex these days. It's not what it used to be at one point in time. Yeah, it is really complex right there, right? Yeah. So what this is showing is a Swiss cheese model, that a lot of things have to line up before an error actually reaches the patient. There are lots of checks and balances. This is Swiss cheese. If you have ever eaten Swiss cheese has holes. And in order for an error to occur, all the holes need to line up and every check and balance needs to fail before what you call the patient harm is concerned. So this is what I want to say. What I want to say is a quote by Paul Batalden. What that is, every system is perfectly designed to achieve the results it gets. It's a little hard to understand, but every system is perfectly designed to achieve the results it gets. Yep. To give you an example, you all must have heard of sports cars, right? What is that? What is that designed for? Is it designed for comfort, speed, or fuel economy?
For speed.
Speed. So if you think of a Ferrari or one of these cars, the system is designed for speed, right? And it gets speed, but you're not as comfortable, yeah? And you're not going to get the fuel economy, right? So if you are designed for safety, you have to be designed for safety. If you want to be designed for safety, you need to think of system solutions, not people solutions, because it's not all about bad people. It's about systems. We need to fix the systems in healthcare. And what is a systems lens? We always focus and blame the individual, but that's at the end, There are institutional factors, there are system factors, there are departmental factors, there are hospital factors, there are teamwork and communication factors, and it's a funnel. And all of these converge. And the bigger ones are outside, which are outside your control. And you as a helpless doctor or nurse is trying to fix and balance with all these, what you call system factors. So the issue is about fixing the system. And this is what we call the Donabedian model. Structures, process, and outcome. You want to have good system structures, good processes in place to get good outcomes. Structure is staffing ratios, properly trained staff, proper reorientation, skills upgraded, processes, standardized processes, and then outcomes that you have. So again, the important thing is most of the errors are due to human error, and the action is at the bottom. If it is human behavior error because of a problem with the system design, 90% of the time, instead of firing or pulling up the healthcare worker, you have to console the worker and say, it's not your fault, it's the system's fault, right? Only if somebody is really doing things that they should not be doing, that's when you punish the people. Which is what you need to do. So if you want a just culture, an organization with a just culture, if you want to improve patient safety, if you punish people all the time for harm, then you're never going to have people speak up. Yeah, so if you want people to speak up, you have to console them, you have to coach them, because you need to understand it's not them being bad, it's just because the system is not designed for safer care. Okay. That's what I wanted to say. So in the science of safety, here are the key lessons. Accept that we all make mistakes, all right? Recognize that harm is the result of a cascade of broken systems. Don't blame the individual, don't blame the nurse, don't point fingers at the nurse or the physician. Then we need to focus on designing safe systems. We need to redesign safe care. We need to look at workflows in hospitals. We need to make sure there are checks and balances. Coach people to make, and then focus on communication. Talk more, discuss. Don't be worried. When you have a concern. Listen when others do, like that mother, and then ultimately accept responsibility for the system in which you work. You don't have to say, this is not my job, this is somebody else's job. That's not what you do. So broadly speaking, to prevent mistakes, you create a culture of safety, and that's what we wanted to talk about, the CUSP program. You focus on the systems and processes, you identify the key processes, you improve those key processes. How do you improve those key processes? You reduce complexity. Systems are too complex. Fewer steps means less opportunity for error. Yeah, you develop reliable processes, you test those processes, and then you create independent checks for those key processes. And at the end, of course, you need to automate, you need to bring technology, you need to bring electronic health record and things like that so that you're able to make decisions quickly and safely. So that is what I wanted to say. And, this was something else that was there for some other examples if we had time, but I think we are out of time, and I'm happy to, I just want to run back to what you call, say that there's a lot of research going on patient safety. Yeah, these are the number of publications by year on patient safety. You're seeing patient safety is gaining a lot of prominence. And it is never too late to start on a journey to patient safety. And patient safety research is important. This is important work. And I will end with the quote by Sir Liam Donaldson, who was the chair of WHO Patient Safety, who said, to make a mistake is human. We are human, so we can make a mistake. There's no problem about that. To cover up is unforgivable. It's not a good idea to cover up. Cover up means to hide that mistake. You don't want to hide that mistake, because if you hide that mistake, what you do is you fail to learn. You don't learn from a mistake, yeah? You make that mistake again, and that is inexcusable, which you can't forgive at all. So with that, I want to say thank you, and I'm happy to take a few questions. Thank you so much.
Okay, thank you so much, Prof. Cyrus, for very enlightening presentation. I have a few questions for you, but I know that this is the student turn to take the question. So there's no question in the chat, but I'm pretty sure that maybe some of the students want to ask directly to Prof. Cyrus.
Sure.
Just raise your hand. Yeah. Any question from the student, from public health and from nursing, and maybe from the Faculty of Pharmacy?
I have one question, Bu Inga.
Okay.
Is it okay for me to have a
Yes,
question?
As long as it's not a very hard one. As long as it's not a hard question. Okay.
Yes, I think it was an interesting lecture. I liked it. I love it. And I want to ask you how to improve the patient safety in the hospital. Which one is the first? Settle the culture first or settle the system?
Right. Good question. So culture eats strategy for breakfast. There is an American saying, culture eats strategy for breakfast. If you don't have a good culture, you can get the best technology, the best systems, and they will not survive or sustain. So the beginning point is to have an acknowledgement that we make mistakes, it's understand, and we need to learn from those mistakes. So culture is important. Hopkins, which is my institution here, had the best technology, but still our culture was not right. Our culture was not open because of hierarchy between medical students, doctors, and nurses. Nobody would speak up because they held their professional autonomy and professional, what you call superiority. It would be challenged. How can a leading physician say, I messed up? So I think it is important from our lessons that culture, shared values, and honesty, and learning and importance of learning that we all make mistakes and we all are human. And so we can make a mistake. That's the first step that needs to occur. And so at Hopkins, they came up with a program for improving culture much later that should have come much before. Because if you have a culture of learning and improvement and openness and transparency without being punitive, which is without punishment, then you are encouraged to report more mistakes. You're encouraged to point mistakes, not to blame people, but to fix the systems. So I don't know if that helps.
Okay. Thank you, Professor.
Welcome.
So, okay, so if I may continue with the Dr. Ardian question. So actually, how long that we need to build the culture based on your experience? Is it like a 2 year or 3 year or 5 years?
So, so this is what I say. This is very variable, and it varies based on leadership. If you have leaders that are committed to drive home an open, honest, and transparent culture for safety, then it can occur sooner. But it also depends on the size of the organization, the history. You know, if you had a culture that focused on blame and punishment and retribution for many, many years, it would take a long time for people to believe in trust and, you know, that be speaking up. So you know, the CUSP program, if it is implemented, it is a comprehensive, the full what you call form of CUSP is comprehensive unit-based safety program. It is culture of every unit. CUSP recognizes that although organizations may have an organizational culture, but there are departmental cultures. And so every department has its own culture. And so you need to have an intervention at the department level. So I'm sure I'm not answering your questions directly, but it is variable. It can depend on many factors, commitment from the leadership, the historical, you know, if you have been punishing people, firing people who are, you know, supposedly blamed for mistakes and errors, then it can take longer. And there's no time period. It can be anywhere from a year to about 3 to 5 years. At Hopkins, it took about, I would say about 5 years at Hopkins, because it had a history. So it's all about history, how long you have been with that. So I don't know if that helps, but.
Okay, thank you. Let's back to the student. Any question from the student or maybe from other college? Okay, while we're waiting, so you're
very, very polite. I mean, I can't believe that. Either that means that either you didn't follow it, or what you call, you're too polite. I don't know what it is. Yeah, or it's too early in the morning, or maybe it's yeah, no.
I have one question actually. It's sent to me privately in my chat from Fatul Munir Darosa. So I just read the question. It's a bit long. So I believe that instead of human being related error, technological approach has also its important role in preventing the error. So the usage of safety medical devices may support both patient safety and healthcare worker safety. So in your perspective, so how much effective is the technological approach in preventing error? So in Indonesia, the cost-related consideration associated with the high-tech medical devices is always being a huge barrier to adopt it. So what do you think about that? Thank you for Pak Fatul. Okay.
So thank you for the question. And so technology is a boon and a bane, and it's good and it's not so good too in some ways. Technology can help prevent mistakes, but technology can also cause mistakes. Yeah. So that has been the experience in the United States, particularly when it comes to electronic health records. You know, when you have physicians that were making prescriptions first by hand, and then it became electronic prescriptions. And then in an electronic prescription, what happens is physicians have a drop-down menu, of the medication. They are typing, and then there's a big list that comes down. There are so many medications, and there are look-alike, sound-alike medications, right? There are medications that look alike, which we just saw, but they also sound alike. And sometimes by error, because they are both next to each other in a drop-down menu, you think you are ordering the right one, but actually you're prescribing a wrong one. And sometimes there are decimal points, there are dosage issues, etc. So while the e-prescribing is great because you know what was prescribed, that goes in the electronic medical record of the patient, that physician knows, they can track dosage, the pharmacy gets the order, and they can dispense the order, the billing can be done as well. It's a great system, it's e-prescribing. But at the same time, there's an opportunity for an error because of this, what you call, then there are what you call clinical decision support systems. Now, CDSS is what we call using intelligence from knowledge management systems, which is what we call most of these electronic health records have. So for instance, there is a database of evidence from literature that is populated in the electronic health record. And when you're prescribing a medication, so there will be contraindications or allergies or things that you should consider before prescribing this drug. So an electronic health record or this technology can help the decision to make a better informed judgment based on his experience, but also some flags and alerts. So technology has been good. But what is the cost of an electronic health record to install in the United States, depending on what it is, from about 2 million to some institutions have spent about $22 million. And that's a lot of money, where do hospitals get that kind of money? And so in the United States, there's a policy that the government supports or cross-subsidizes the purchase of some of these electronic health records because they want to build a data highway so that the patient records can be shared. So when you go from one hospital to another hospital, it's possible for them, or to a doctor, to a physician. But the answer is yes, technology is a boon and a bane. It can help, it can be expensive, and that's where government policy needs to work to lower the costs of technology. So one last example. When we were running the Safe Surgery program from WHO has a safe surgery program. One of the requirements or equipment for safe surgery is pulse oximeter. A pulse oximeter, if you are in an operating room, is a very important device that is needed to monitor the blood gases and the blood oxygen level so that when the surgery is being performed, this is an important information for the anesthetist, for anesthesia and all. This was very expensive. It was very hard to procure in low and middle income countries. And so WHO worked with suppliers and vendors to come up with the low cost pulse oximeters. So governments can do things to motivate vendors to lower the price of technology. Look at the case of ventilators now in the pandemic. Ventilators are in short supply. Countries are doing what they can to sort of, provide support to vendors to lower the costs, to come up with different ideas for ventilators. So I don't know if this helps, but a very good question.
Okay, thank you for the answer. I think if we look at the implementation of health information technology and why it becomes a big issue, especially in developing country or maybe in middle income country, I think one of the reasons is people or the government not aware on the cost of the accident. Because if we just calculate the cost of accident or the the economic cost of the incident itself for the patient, for the hospital, and for the system, the whole system. I think it costs more than the installment of the devices. But yeah, I think we need to work together with the government and also the I think overseas partner. Okay, and we have 2 questions here. So the second question is from the Islamic Hospital in Surabaya. Pak Budi Setianto is in the chat. So near miss incident at the hospital is often occur, especially at the time of the patient, of the time of the identity of inpatient prescription. Okay, thank you for sharing the screen. And yeah, are recurring near miss even so dangerous? And if yes, and why? Thank you.
Yeah, so thank you for this question. And again, for the benefit of the larger population, a near miss is a term that is borrowed from the aviation industry. A near miss is a very close miss. It's you just narrowly missed an error. So it could have been an error. So this person is saying is that it occurs at the time of identity of inpatient prescriptions. If I'm understanding is that we identify this and we recover. Is it dangerous? Yes. Near misses are dangerous and they need to be taken care of. And if you are finding that you have more near miss at a certain juncture, that is what we would use a tool called FMEA. It's a failure modes and effects analysis to map a process of your prescription process. What are the failure modes? Where do these failures occur? How often do these failures occur? What is the impact of this failure? Is it a large impact or is it a small impact? And then what's the score associated with that? So you multiply the likelihood of the mistake occurring, how often, what's the impact, and you come to a score. And those failure modes that have a high score are the ones that you really want to focus on first. And so it seems like that's one of those areas where a near miss, because if there is a near miss, it means sometimes there will not be a near miss and you will miss, you will have an adverse event. Yeah.
Okay, thank you. Maybe we can move to the next question from Dr. Mary. The question is about the hierarchy and seniority. This is yes, very significant in Indonesian culture. So the question is, was John Hopkins have this kind of experiences? So what's related with the hierarchy and seniority? This is usually related with the feel of reluctant to report the error because it was conducted by other college, or maybe afraid to speak up or something like that. So yes.
So very good question. And this is in healthcare. Thank you, Dr. Mary. Truly appreciate this question. And I'm glad you're asking this question. This is exactly talking about culture. This is again going back to culture. The culture needs to be less hierarchical and more team-based. And there are programs that need to be implemented and leadership. So leadership needs to be committed that at the end of the day, the cause of the patient is the main cause, and we need to communicate with each other. And it takes time. This happened at Johns Hopkins. And if we talk about the cusp, I can show you data about the culture, what the nurses thought the culture was, what the doctors thought the culture was, and hierarchy is there in every institution, but it took a long time, but sustained leadership and the program to help support that we are here for the patient. We all make mistakes and it's okay. And we are partners in the care of the patient. And so we should, what you call, work together. So it's not easy, it's hard work, but it's sustained work. Can it be done? The answer is yes. Today, a nurse, the Toyota model, I don't know if you're familiar with pulling the cord. Toyota came up with the lean manufacturing philosophy and lean sigma and Six Sigma. So in Toyota, there's a assembly line where the car is manufactured at different junctures to finally be a complete car, complete automotive. So anybody who feels there is a mistake or something, anybody, it could be the lowest paid worker, can actually pull a cord and the whole assembly line stops. And nobody can question that. And that problem is fixed. And only after the problem is fixed can the assembly line begin. I think in healthcare, we need to look at patient first and patient-centered care. And I think the day we all acknowledge that it doesn't matter who is able to find a problem and fix it, as long as it's done from a team perspective, it's okay. I think that it takes time. And you're right, a good question. The right incentives need to be put in place. In the United States, for instance, hospitals actually promoted reporting of errors because people were, so the government actually put money aside for hospitals if they started reporting errors because they wanted people to report errors. And so again, incentives need to be aligned, leadership needs to be committed. You need to actually have role models in different parts of the institution, and it's a lot of work. So you're right, but it did happen at Hopkins, and a nurse can challenge a doctor in the operating room and can stop a procedure.
Okay, thank you so much. I think this leads to our last question. I'm sorry, but because of time limitation. So this is a question from our colleagues from the nursing faculty, Ibu Ida Widiati. So Prof. Cyrus, you said that culture is the important thing that should be established for patient safety. So depend on your experience, what kind of steps that we should do to build the culture? Thank you.
Yeah. So that's another session in itself. What do we do to build culture? General culture of safety? Is that what the question is? General culture of safety?
Yes, I think.
Yeah. So there are programs for promoting the culture. The first thing is you want to encourage people to speak up, right? You want people to speak up. So you should reward people, or actually not at least punish people from speaking up, right? And so if people speak up, their voice needs to be heard, whether it is a nurse, whether it is a physician, whether it is any healthcare worker. Then there's a program where there's a coach that goes along with every department, and they have a meeting once in a month, and everybody can say, how are we going to harm the next patient in our unit? And it's anonymous. People write it down and they put it in a in a box, and the results are analyzed. And without naming anybody, there is what you call discussion on how that error might occur and why somebody thinks that these errors are likely to occur in a unit. Then usually there is a leader that is appointed to the unit, a leader that is appointed to that unit. And then that unit leader takes those problems, tries to fix those problems along with the team members. And every quarter they come up with, or every month, depending on how many, they come up with a new problem, and they get into the habit of accepting that there are problems, accepting that there are challenges, and then over time it becomes routine. It's not like a big deal that somebody says, the next patient I know how we are going to harm. So it takes time, but that's the CUSP program. And we can talk more about it if there is interest. I can explain the entire program, how it works. There's evidence that this program works and improves clinical outcomes and teamwork and communication. And if there is an interest, I'm happy to discuss that and share how this program was rolled out at Hopkins. and the effect of that program. Thank you.
Okay, thank you so much. I saw someone raise hand. Do you want to ask question? I think one of the students from public health. Okay. Okay, no one is here. Okay, Prof. Cyrus, I think yes, this is only the time that finally make us to need to finish this session. Thank you so much for the lecture. It was very enlightening and inspiring as well. So yeah, we learned a lot from today's presentation, and could wait for the next Saturday to learn something new, whether we want to focus on the CASP program, because the team step is included in the program as well, right?
Right.
So,
Yeah.
or maybe we can discuss about that further. Okay, thank you so much. We still have like a 460 audience in here. It means that the lecture is very interesting and people keep staying until it's finished. Okay, thank you so much from. Okay, thank you so much, Prof. Cyrus. Yeah, okay.
Thank you
See you
so much.
again next Saturday.
Next week.
Yeah. Okay.
Thank you. Thank you.
Yeah.
Thank you very much.
Thank you. Yeah.
Thank you. Bye.
Mohon izin live Bu Inge.
Monggo,
izin
monggo.
live.
Mas
Makasih.
Dani, makasih banyak Mas Dani ya